This week on the BackTable podcast.
So the devices are going to continue to change. They're going to continue to get better. But like I said, I think the real key to anything we do is know exactly the device that you're using, know how to have it ready, know what its benefit is, know what it's not good at. The reps are still, remember, a selling product. There's a lot of competing products out there, but know what's best for you in your hands, for your patient population, in your community, your institution, what you can see, what you can't see, what your imaging is good at. And like I said, don't be afraid to ask questions either. I think going forward, our field is one of consistent growth, consistent innovation. And status quo is never going to be accepted, and it never has been. It's been a real privilege to be a part of that too.
RADPAD was developed by physicians for physicians. Clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the BackTable podcast.
This is Michael Barraza returning as your host. I'm honored to be joined by Dr. Wayne Olan, the Director of Minimally Invasive Neurosurgery at George Washington University. Wayne, thank you for sharing your day with us.
Oh, Mike, thank you so much for having me. I think it really, important to point out I am an interventional neuroradiologist by training, but I am part of the neurosurgery group at GW.
So you're under the neurosurgery umbrella and you're not in the Department of Radiology.
About 12 years ago, I got hired. Our chairman the chairman at the time of neurosurgery was a chairman who was a neurosurgeon when I was training. He was an attending when I was training, and he brought me back. I was at GW. I did my training there. I did my neuro IR there. I did neuroradiology there as well. In fact, I ended up being section chief of neuroradiology there at one point, and I was also program director of the radiology residency. And then after about 8 or 9 years, I went out into private practice. I was out in Bethesda, Maryland at Hopkins, part of the Hopkins program. And then after that, about 12 years ago, an old colleague called me. At that point, interventional neuroradiology had become part of neurosurgery at GW, but he called me and asked me if I wanted. And, with all due respect, quickest way for radiologists to get a raise is join the neurosurgery group, right?
Yeah, absolutely. That's cool.
So I joined there about 12 years ago, neurosurgery appointment. I still have a radiology appointment. And in fact, we have a IR residency and fellowship that I am on faculty for, and we train our IR residents and fellows in stroke, in interventional spine as well. They do carotid interventions with us also.
Man,
and I think
that's awesome.
That sets them up, when they get out, to be of value to the practices that they join.
Absolutely. That's a great experience. Wayne, myself, I trained in body interventional radiology. And about 5 years ago, I joined a practice that, the body interventional program that had a neuro IR, but my group covers stroke for our, level 1 center. Actually, we're a comprehensive stroke center now. And, we've been covering stroke interventions for a while. And so I had to pick that up right when I started this job. And I would love to have had that experience beforehand. That's great.
Well, thankfully, and we cover now our major medical center, which is, as you said, comprehensive. And then we have 2 thrombectomy capable centers that we cover, about to probably add a 4th in the very near future. And one of the upsides, and this, is what we've done in interventional radiology and interventional neuroradiology is continue to develop new procedures, new techniques. And then you do them and you perfect them for 5 years. And then, with all due respect, someone tries to steal them, right?
Yeah.
Some other subspecialty comes after it. But this is really the first time really in my career that I am unbelievably in demand, because stroke intervention is so desired by institutions and by medical systems, because one, it's so good for the patient, right? I mean, ridiculous. I mean, you could have, and the insurance companies are really willing to, because it saves them 20 years essentially of rehab, maybe, if you can make a difference. And so it's really the first time in my career that we are in such demand. And it's been a real privilege. It's also, been life-changing for not just the patients, but for us as well. I mean, it's one of the more emotionally rewarding procedures that we do.
It's my favorite thing I do.
Favorite thing. And you could change people's life. And I like to say, we change people's stars. Like we get to reach up into the sky and change their stars. And with all due respect, a procedure that is fairly straightforward.
It's straightforward, but when it works, it's dramatic.
Dramatic.
Yeah. And it certainly makes it easier to take those 3 a.m. stroke calls, which fortunately aren't as common as the daytime ones, but as you know, they happen.
Oh, there's no doubt about it. Thankfully, people don't wake up from a stroke, so they either get them in the morning or they get them during the course of the day. But just like you say, the drive-in, and I get all that, is terrible. When you're in the case, there's not much that's better.
No, you're wide awake, you're in it. The nighttime cases to me are usually transfer cases.
Yeah, for us, it's 6 of one, half a dozen of another. I'm on the White House Congressional Department of Defense, State Department medical staff. So we try and stay ready, especially as all these guys keep getting older and older. We just try and stay ready. So it's been, like I said, and I'm sure if you'd feel the same way. Honestly, when you really peel it down, it's a privilege. It's one of the great privileges in our career to change people's life just like that in an instant,
No, I have to admit, we've had some other services. The neurology team has wanted to join us taking stroke call, and we shut it down. We want to keep it.
Well, everybody always says, "Oh, I want to help you."
No,
yeah, tell me. But when I need help, I'll ask for it. Everybody comes up to you. I want to help you.
You can take 25% less calls. Like, give me 25% more of this.
Right. Hey, I want to really help you out. Oh, you really don't.
No, we shut it down, and I'm glad we have.
Good for you.
How does that work for you guys covering 3 hospitals in a night?
We have 3 guys pretty much who cover most of the stroke call. 1 guy is predominantly on call. And to be honest, in maybe 5 years, we probably had 2 calls once at institutions. So it's not been terrible. And the other thing, and you know this, stroke cases aren't 3-hour cases. No, they're, and as you get quicker and I think going forward, and obviously that's not the topic of the discussion, but you're going to be judged by, first pass success. But I think cost is a big issue too, keeping your costs down. And then we have all these time, tables that we're trying to match. So, if you do get called in the middle of a case, usually you can be at the next case. And the institutions aren't that far apart. So, and our techs still have to come in. Everybody still has to come in. We're not in-house like some institutions are. So it hasn't been an issue just yet.
Yeah, not yet. We have a backup system in place, and for the rare circumstances that it happens.
For comprehensive, you have to.
Yeah.
You have to have a backup system in place. And then, for us, it just hasn't been that much of an issue yet. And you have to be dedicated to it, though. Because when the time comes, you got to get on your horse. And we do.
Yeah. So, we're going to be spending most of our time focused on carotid interventions, primarily carotid stenting, both, within and outside of the setting of stroke. And, you've been able to watch how carotid stenting has evolved over the course of your career. Would you mind telling us a little bit about how that has looked and some of the history?
Well, I've had a great privilege of the first percutaneous angioplasty of a carotid was done by a guy named Chuck Kerber out west. And for anybody who's my age who knows Dr. Kerber, he was an interventional neuroradiologist, one of the first guys trained, part of this initial core of interventional neuroradiologists who really changed medicine. In dark caves in Jackson Hole, they beat drums and talked about bad outcomes. But they were doing stuff and bending catheters with heat and things that we can only dream about now. The devices we have now, in theory, really make it much more straightforward and much more simple, but we also have to use less imagination than those guys did. And there was the pure art of medicine for Dr. Kerber. And then the first carotid stent, I think, was done in Germany by a guy named Klaus Matthias. And, the risk of, and that was in, I think, 1989. The risk of these procedures, and this, and we started doing them, you weren't really doing them because it was a routine thing. You were doing them, hey, I got this guy. That's how those conversations all started.
Absolutely.
I got this guy, and I don't want to, he's had radiation, or he has a tumor, or, like you see, we had talked about before, he's bleeding from somewhere, or I got this guy, and his mandible, his bifurcation's too high for an endarterectomy, or he's not a candidate for general anesthesia, or his arch is kind of Gothic, or he doesn't have crossfill in his head. Because as you know, when I trained, everybody who did endarterectomy used to shunt people. So they would put a shunt in and shunt the lesion before they clamp the carotid. Now it's different. Now most people just cross-clamp the carotid, and they will use EEG monitoring to see if the patient's having a problem, that they don't have cross-filling. So it's a lot different. Guys sort of the generation above me shunted everything. So the history of endarterectomies changed too, but we first got into the carotid intervention business because guys started every sentence with, hey, I got a guy, could you just? You know that thing you did in the leg? Can you do it? Because, he's not a candidate for this. And that's kind of how we got into it. And then stroke kind of occurs. And if you're going to treat strokes, there's going to be a percentage of patients, let's use the term 20, that are going to have a carotid lesion that you're going to have to manage just to treat their stroke.
Right.
Or manage it on the way out to make sure they don't have another. And so the carotid stent or interventional carotid business has become out of necessity. And one of the things that really strikes me is I'm old enough to remember how IVC filters came around and the business of IVC filters. They kind of started the same way. Now, IVC filters were all done in the OR. Then all of a sudden you had somebody that needed one in the middle of the night. So they called the radiologist. It's the middle of the night. Well, yeah, I need one now. And now that's a good case for radiology. Or it was a difficult case. Whatever, or the patient, to be honest, had the same last name as somebody in the OR, so they knew that procedure may have been a little bit less invasive. And over the course of time, because it became really apparent, IVC filters have become the business of interventional radiology. It just is. And then removing them. And stenting has kind of gone that way. There's a lot of data. The data really requires a lot of, you have to almost interpret it because it doesn't really separate the two procedures one way or the other based on skill of the operators and things like that. It's really hard to compare the apples to the apples or even the apples to the oranges. And I think what you're left to do is look at your own community. And that's really the best place to compare stenting to surgery or endarterectomy is in your community. Who are your vascular surgeons doing it? Who are the operators doing the carotid stents? Are they operators who are experienced to do carotid stents? Because a lot of the early carotid stent data was done by inexperienced operators. And, and then the questions come in is, how does and what's your referral patterns like? Where are they coming from? And for us, your outcomes at the end of the day are going to predict what's coming your way, but they're also going to tell your story. If you're having bad outcomes, you're going to have a very short life doing this. And thankfully for us, it hasn't been that way. We've been very, very successful doing these procedures. And in our institution, we do the majority of carotid interventions.
Who's referring the majority of them, the ones that you don't find on your own?
We get a lot from cardiologists. And honestly, because they do a lot of carotid screening. We get a lot from cardiothoracic surgeons as well, because prior to surgery, they're looking at carotids to make sure that the patients don't have disease. And it's very interesting on those patients, asymptomatic carotids don't have to be quite as stenotic as you might have thought looking at the literature. Oh, I need you to stent one of them. Just stent one of them. I don't care.
Yeah.
But we see them come from, a lot of them, and then a lot of them, we're getting them from vascular surgery as well. We have a really good relationship with the vascular surgeons in our institution. And they come from inside of neurosurgery. They come from all over the community. But predominantly they're from the cardiology arena because they screen most of the carotids throughout the course of a patient's life, right? A patient, in their 70s is going to their cardiologist at least once a year or getting their carotid, ultrasounds every 6 months. And, that kind of keeps us from having to do that in the patients that once we stent or intervene on a patient, then we're following them too. But the ones that quote unquote coming off the street, they're usually coming from someone else's office. But our referral base has gotten pretty huge and fairly widespread.
Yeah. Has it been challenging kind of working with vascular surgeons in terms of, endarterectomy and TCAR, kind of figuring out where stenting works in?
Well, two things. One, I'm sure the stenting does work in. TCAR is an interesting animal. And I think before you comment on it, I think it's important to know how to do it.
Yeah, I don't.
Once you see it, you're like, it's a fairly invasive procedure. And so we all played around, just so I can comment. I try very hard, Mike, I'm like Mikey from the old Life commercials, remember? Like, I'll try everything because I think there's no value to my comment if I hadn't put my hands on it. And our vascular surgeons are very good, but patients would like a less invasive procedure. There's no doubt about it. And it carries with it a lot of more morbidity. Nobody's taking a facial nerve with a carotid stent. They just aren't. Nobody's getting a wound infection. You just don't get them. But there are patients, I'm sure, that an endarterectomy is a good patients are good candidates for it, and they'll go to a vascular surgeon's office. But we get a lot of referrals from vascular surgery because there's also those that are not amenable to surgery. The patient's not a great candidate for general anesthesia. We don't use general anesthesia ever. Their mandible, the bifurcation's behind the mandible, so nobody can get to it, or other reasons why that the patient, radiation, previous radiation, or a re-stenosis, all those, that's what the correlation with the IVC filter kind of comes back. The tougher cases, we're good enough for those. We're good enough to do all the tough ones. At some point, we'll graduate up to getting the routine ones, So, but for us, it's more than enough. Our results have been, I think, you can't question them, our outcomes. And the institution really keeps track of that. And so our institutional data is what supports us and allows us to continue to grow this practice. Stroke, on the other hand, also allows you to, or forces you, so to speak, to have to intervene in the carotid.
Right.
Nobody's coming in with a stroke and going to get an endarterectomy. So we're good enough to do those as well.
Right.
And, there you have to, you got to be fairly efficient in what you do and how you get there, and then how you choose. And everybody has their own sort of algorithm. Do I stent first and then go distal, or do I go distal and stent back on my way out? And I think a lot of that depends on whether you can even intervene. The size of the amount of carotid you have there will allow you to intervene. If it doesn't, you obviously have to stent on your way in.
I want to get into that in more detail in a bit.
Sure.
And hear how you approach that. Let's start with the more routine carotid stenting cases, the ones that are coming from home. How do you manage those? Do you see them first in clinic?
I like, and I'm a heretic, I like to do a diagnostic angiogram on everybody prior to a stent. I think it gives me 2 20-minute procedures instead of 1 3-hour procedure. Do you know what I mean? I think it allows me to prepare myself. It allows me, because the platform for the stent is very different than it is for just a diagnostic angiogram. And the other thing is remember, you have to put people on antiplatelet. And I'm going to tell you, one of the great advances in carotid intervention is Verify Now. So we get a Verify Now, and I was stunned that 30% of people are not Plavix responders. That is a massive number. Massive. So, and Verify Now, if their Verify Now shows that they're not a Plavix responder, you got to adjust, right? So at the time. So I like to do a diagnostic angiogram, measure so I could prove the point that this patient requires an intervention, and then I can go talk to them about it. Usually people don't have just purely unilateral disease. It may be one's worse than the other, and then you're also doing a full stroke workup. You're looking at a vertebral origin, what is their intracranial collateral flow? How much of the circle of Willis do they have? Are they cross-filling from side to side if they need to? Changes that you're going to have to appreciate after you put a stent in. I also don't use anesthesia for diagnostic angiograms. We do everything with moderate sedation. Now, having said that, I use anesthesia for every single carotid stent.
Okay.
I don't, though, put them to sleep. And I will tell you, and I hate to say it out loud, but man, one of the most fun things to do is not tell the anesthesiologist when you blow up the balloon after. If you, just for fun, if we have little bits of fun in the room, that's one of the places.
I've failed to warn them before.
Right. Although if I have some who are my very close friends and they'll walk in and go, you better warn me. Having said that, though, but that's why they're there. They're better physicians than me. Let's call it what it is. But then how do you manage that patient that's not a Plavix responder? You cancel the case? Well, we don't. So Brilinta, interestingly, will say it works, depending on what you read, anywhere from 30 minutes. Maybe, maybe not. But we'll still use an IV antiplatelet 2B3A antagonist. We like to still use Integrilin, but you have to be prepared to move to Aggrastat because Integrilin is no longer being manufactured. So our hospital has this massive surplus of it, but you got to be ready to move over whenever that time comes when you can't get it anymore. So we can still go on to the procedure, and then the patient stays on Brilinta post. We keep them for one night because, to be honest, I think insurance companies are requiring it. I do believe if we have this conversation, Mike, 5 years from now, outpatient carotid stenting is going to be a thing. There's no reason why it isn't. It's a simple procedure, to be honest. The stent part takes about 15 to 20 minutes, which is like perfect for my attention span.
Are you doing them all from femoral access?
99% of them if I can. Even aggressive. And that's a great question, because what about, the Gothic left carotid, right? A really sort of Sim2 left carotid. And I think if you're doing carotid stents, you at least have to be comfortable. One, we'll talk a little bit about the different stents, or at least their different characteristics. But there is something called an APTUS, APTUS sheath. And it's a steerable sheath. But I swear to God, it's like the hardest rail you've ever felt. And if you hook and we use it, but if you hook a left carotid with it and really tighten the curve into that carotid, we can stent right from there. I like femoral access. I know you're making a face. Try it on the table. You'll see what I mean.
It sounds awesome.
You will see what I mean. And it could sit right there. You could almost stent right from the bifurcation. The length of it extends long enough. You just go up from there with your distal protection and your stent, because that thing's not moving.
Man.
I mean, if an earthquake happened,
How big is this thing?
That wouldn't, it's a 7 French.
That's great.
So APTUS, Medtronic makes one too.
Okay.
We happen to use that one. Mostly my carotid stents, I use a shuttle. I'll go through a shuttle sheath, and I don't use a TUI. I use a sheath adapter, the valve, just because it's one less blood flow thing to manage. But same kind of thing. And I close everybody, with some closure device. But I think it's important to also know, if you have a lesion that's not really tortuous, if you have a tortuous lesion, you really have to think about an open cell design, because they curve better. They turn better, they curve better, they hold themselves. And everybody has different ones. Some people use an AccuLink. It depends on what you use, right? But my go-to product, there's no doubt, is a carotid wall stent. And the reason why is the carotid wall stent, which is a closed cell design, and it's also stainless steel, it's not nitinol, doesn't jump, but it has this really, really tapered hydrophilic tip to it. And you and I touched on it prior when we were talking. That thing, I rarely, if ever, predilate. And this thing has done nothing but continue to surprise me with the amount of stenosis of a lesion that it can cross. So if I can cross the lesion with my filter wire, and I deploy my filter wire, I'm very comfortable usually that the carotid wall stent will get across. Now, having said that, if you have a tortuous lesion, you might have to start thinking about an open cell design and then AccuLink, but then you're using a different distal protection. There are 2 interesting products coming. There's a precise stent also, which is also open cell. But then there's 2 stents that have just kind of come out that are really interesting. And like I said, whether you choose to use them or not, I think it's important just to know about, because people will ask, and marketing is such, and people are savvy, they read the internet. There's a Contego, C-O-N-T-E-G-O. The Contego stent is interesting because it's all in one. And I have been begging, and I mean seriously, Mike, begging, that somebody will make your filter wire capture device onto your balloon.
Yeah.
Just save you a step, right?
Right.
You blow up your balloon, boom, pull your filter wire in, and you're done.
That sounds great.
Instead, I blow up my balloon. I have to take my balloon off my filter wire, and then I got to go back up with my filter wire device, my capture. Contego is kind of all in one. It's kind of back to a balloon-mounted stent. It's all in one. But they market themselves very interestingly, and I didn't even know the answer to this question. How big are the holes in most distal protection devices? I didn't know. Me neither. They're 110 microns, most of them. Contego, they say that most lesions that get through are 70 microns, or between 110 and 70. I've not seen that happen ever, but their distal protection device is 70 microns. That's where the holes in their mesh. And they claim that it'll capture more stuff. Now, I think if you're throwing stuff, then maybe you should think about using that. We haven't had that problem. I'm sure you guys haven't either. I don't think I've ever opened up a distal protection device on the table and I show my students, my fellows, my residents every single time. There's never anything in it. Having said that, the one hack I will always tell you, never, ever, unless you want to do a run with your distal protection up, because it's going to make you think you gave the patient a stroke.
Okay.
Because the flow will just be really slow.
Yeah, I don't think I have. Yeah.
Well, don't do it. Because the first time, and any mistake or anything I ever tell you, it's a mistake I made. One of the first cases I ever did with distal protection, that's what I did, a run. Oh, you do a run. Let's get a run. And the flow was so slow. I was like, what happened? And then I took down the distal protection. Well, perfect. So try not to do runs with and a lot of guys like to get pictures, take a picture, get a run. Get your distal protection out or it's going to make you nervous. But the other thing is, just know your product. I think it's really important that, because each of them are different, and especially the distal protection devices are different. The way you deploy stents is different. The nice thing about a stainless steel stent is it's not nitinol. You don't have to let it heat up. But whatever device you're using, and I think this crosses over even outside carotid interventions, you need to know that device soup to nuts. Don't rely on the rep. If you have to rely on a rep to teach you how to use the product, you probably shouldn't be using the product. Now, that doesn't mean the rep can't be additive in the room. Don't get me wrong. But you should be able to prep the device. You don't need to text it. Now, that doesn't mean you're doing it, but you need to know how to do it. Because I don't know how many times I've turned back around and watched it and it wasn't being done right. Because at the end of the day, the only name that matters in the room is yours and mine. Not the tech, not the resident, not the rep, nobody else's. Yours and mine. And so you got to know everything soup to nuts. So regardless of what device you use, make sure you know how to use it. You know how to prep it. You know how to deploy it. You know how to recapture it if you have to.
What wire do you prefer to use when you're doing your carotid stenting?
Great question. So I will, and God, if we were going to talk about stroke, you'd call me a heretic, but I like to swap out everything over a Terumo Advantage. So I'll do my swap with a Terumo Advantage. Now, I will also tell you, if the lesion isn't so stenotic and the Terumo Advantage goes into the internal without any trauma, I have no problem leaving it there for my exchange.
Right. I'm with you.
I will anticoagulate the patient or put them on heparin once I deploy my filter wire, but I don't do it prior to that. Once I have my shuttle where I want it sitting, my sheath below, in my common, and I pull out my Terumo Advantage. Now, I will use that every now and then as a buddy wire and leave it. And it's been great for that. Great. And surprisingly great. I've also used a V18 control as a buddy wire if I've had to. I don't love to, but if I have to, sometimes you have to. Just what it is. But more often than not, the filter wire EZ is really great at navigating tight lesions and getting across them without having to pre-dilate. Then I get that up, and then I will deploy it, but just prior to deploying it, I'll anticoagulate the patient with usually a weight-based dose of heparin. I don't put them on a drip usually after. If you remember in the old days, before we had antiplatelet, these patients used to lay on our table. Before we had distal protection, they'd lay on the table for 30 minutes. And we'd do a run in 30 minutes to see if there was platelet aggregation. And if they had platelet aggregation, we had to give them referral, which still gives me PTSD, that whole, you hear me look at me, and so now we don't do that. But so I know the history of it. That first 30 minutes, you got to have your antiplatelet on board. And it's great to have the heparin there. So now I pull. So now, we've had our distal protection up. We've deployed our stent. And if I have to, remember, at that point, I'll go up with a Sterling balloon usually. This is another hack. I don't prep my balloon.
Okay.
With contrast.
Okay.
Why not? I just put saline in it. Why? Because when the balloon opens, you see the stent open.
Right.
But if I need to get that balloon,
if
I need to get the balloon down, the last thing I want in that balloon is maple syrup. And that's what contrast is. So I don't prep the balloon, interestingly. The first time I ever did that, one of my colleagues was like, dude, you're out of your mind. What if there's air or whatever? It's not rupturing. I don't think I've ever ruptured a balloon. But the other thing, I don't use an insufflator. I use my hand. And I watch the stent open. And I'm not really chasing a 100%, get back to the normal caliber of the vessel. But I am wanting it to be significantly open. And if you start getting into bradycardia, things like that, I'll back off a little bit. But I'll gently take a 10 cc syringe, fill it with saline, have a second 10 cc syringe empty, inflate my balloon, watch my stent open, and then pull my balloon down, pull it out. I'll wait a second, and I go up and recapture my distal protection. If your distal protection catches, and there are times it'll catch on the edge of the stent, depending. The filter wire does have a la carte hooked one, so that'll get you off of that. But if you have to kind of play around a little bit every now and then to get across it. Or you can take it out and put a little bend on it. So if you have to do that, you do that. So then I'll usually get runs in the neck. I'll usually get a run in the head just to make sure everything looks great. I usually, it's fine. And then I usually close everything with a closure device. I still love AngioSeal. People do what they use. Everybody use whatever they use. But like I said, I think the real takeaway is know your devices. Be efficient, right? Just be efficient. And that's why I like doing them in 2 procedures. I'm much more efficient. I've decided what I'm using. I've decided the stent I'm using. I'm not sitting down taking measurements. All that stuff's already done. Patient knows what they're getting. They know what to expect. I have my antiplatelet on board, so I'm not going to get into a growing complication from the diagnostic angiogram if I'm gonna. And we've been really blessed. And like I said, this is one of those procedures. Again, it's really efficient. It's quick to do. They're a lot of fun. There is another stent that's coming down the pike, which is really kind of interesting. It's called the Inspire. I don't know if you've seen it. It's an open cell design stent. I think somebody said it just recently got approved, which it might have, but it's an open cell design stent. So it's supposed to be good for tortuous lesions, but it's covered with a mesh. So it basically has an open cell frame with closed cell protection. Now, I'm going to say in my experience, I have not seen plaque get launched from open cells. I just haven't. Maybe I'm not really aggressive blasting the stuff, but the stent's not opening that much on its own until you put the balloon in, and then the balloon pretty much plasters everything to the wall. So we haven't seen that much of that, but there is enough out there, or at least fear of that out there, whether it's a real fear or not a real fear, that they've designed this stent with basically a mesh over the stent to protect from that happening. So somebody must be having plaque get launched distal. I don't know who that is, but we just aren't having it. So I'm pretty good using what we use, but you got to have, an open cell in your mind. And then we're talking about carotid bifurcation lesions, but what about at the skull base, or what about somewhere else in the neck, which we get? And usually those are much more tortuous lesions or in a dissection. And there you're going to use an open cell stent. So you have to have one in your sort of gun belt that you're comfortable with. And so I think,
when
like
you
I
talk
said,
about the ones that are higher up, skull base, how are you sizing those compared to how you do it, at a carotid bifurcation?
well, I'm not, and to be honest, and whether I sound like a heretic or not, I apologize, but I'm not chasing an exact millimeter. Most of these stents will open to what the vessel allows them to open to. And then the balloon, if you're going to balloon it, then allows you to change that stent size, basically. Now, the problem with some of them, especially the carotid wall stent, is you got to be prepared that the length of the stent is much greater if you don't open it to whatever its capacity is. So you just have to allow for that. Is there a problem with the stent being too long? Probably not. Years and years ago, when I started, we were always nervous about covering the external even. Now nobody even thinks twice, right? We put pipelines across the ophthalmic all day, every day. If the flow is great enough, the vessel's going to stay open. So we don't really think twice about that. But it's still, and then how do you follow them, right? So the question is how long. Patients will always also, something you kind of touched on. They'll ask you about the antiplatelet because some of it will affect their lifestyle. Like I just stented a guy, no joke, Secret Service agent, fires his rifle every day. He's a sniper. And he was getting bruises on his shoulder from the gun recoil. And I had him on Plavix. I was like, dude, Plavix is not negotiable for 6 weeks. For 6 weeks is not negotiable, then I'll talk to you. But for the first 6 weeks, till that stent intimalizes, and that's the reason. And then maybe I'll keep him on aspirin, but he's staying on some antiplatelet after that. And then he'll have to figure out some sort of job alteration to stay alive if he does. But
I've been insisting on 3 months.
6 weeks for me it's not negotiable even. I don't care, it's just not. And it's worked out fine for us. And in dual antiplatelet, it's a very big deal. And I know I'm going to get stuff for doing this, but we haven't seen a lot of difference with just sort of Plavix, whether it's with aspirin or without. You use dual antiplatelet because that's what people say.
Exactly. That's why I'm using them.
We haven't. If somebody wanted, if somebody was bleeding at 3 or 4 weeks, I'll stop the aspirin before I stop the Plavix. And that's usually it's worked like a champ, by the way. And it satisfies the patient. Oh, we did something.
So let's talk about carotid stenting in the acute setting. We'll see a lot, the patients who come in with stroke symptoms, they get their workup, and the CTA will show an occlusion of the ICA origin. How are you guys approaching those? I should clarify, because we'll talk about the intracranial lesions in a bit, but this one, ICA only. and not carotid terminus. I mean, like
So
ICA
we're saying
origin.
the distal, there's no stroke distal. Let's start
Nothing
with that
distal,
case.
just
Right.
ICA origin, but
But it's
acute
ICA
symptoms.
origin stenosis, not occlusion.
Well, on CTA, it looks like an occlusion.
Well, you do the angio. Now let's say it's occluded. It's occluded.
Yeah.
So they survive the occlusion. A lot of those patients were not opening, depending on what their symptoms were. They've now survived the occlusion. We're going to do a full diagnostic to see where they're getting their collateral from. Now, the patient that's incredibly dangerous, though, is that patient with a very high-grade stenosis, because they're really at risk. So that's a patient, and we kind of talked about it. Make decisions right there. You can give them 2B3A antagonists right there on the table. You can possibly, 20 minutes, you can give them Brilinta on the table if you had to. You already have to, and I can go ahead and stent them right away, right? If we had to. That patient who comes in symptomatic, and they came in as a stroke workup or whatever it was. That patient, and they usually do very well. And, and then, we kind of touched on a little bit about with dissections, and you get those all the time, right? A patient comes in with a traumatic dissection and they're symptomatic. So those are the patients you kind of, if they're asymptomatic, we're usually going to watch those and try and let them heal. But if they're symptomatic, you might have to go get them. And if you do, then you're treating them sort of the same way, whether you have to go in and out of the lumen, whatever you have to do. But still, in those patients, you're dealing with the antiplatelet the same way if you have to.
So for the dissections, the symptomatic dissections, one of the challenges is that it looks abnormal all the way up. And so how high are you stenting with these? How do you know where to stop?
Well, it depends, right? One, if you have a true lumen all the way, you could stent, if it gets inside the skull base, a lot of times it'll stop there or just get just distal to the skull base because it's kind of fixed after that. I'll stent to there. If you have to pop in and out and form a new true lumen, then you're going to have to stent the length of that sort of
that
navigation. To me, in a lot of ways, sometimes, the tougher case that we're talking about isn't necessarily that guy, but it's the case you kind of touched on in the stroke patient, where you may have a distal occlusion and somebody says they also have a carotid occlusion. Interestingly, I think that's one, first and foremost, horribly overcalled. If the blood has nowhere to go, it's going to look like a standing column, and you have to make that diagnosis. And then with respect to stenting in the face of a stroke, I think you have to make a real hard decision. Am I stenting prior to the intervention? But if I can get the device through, I'm stenting after, because I want to get blood flow in their head first. Having said that, though, and 10 years ago, what do you do with your antiplatelet in the face of a stroke? Your neurologist doesn't want it. They don't want it. So, because, they don't want heparin, so what are you doing in the face of a carotid stent, right? And in the face of a patient who may have had a stroke? I think you're handcuffed here a little bit. And so we'll absolutely, in those patients, always use the IV 2B3A, right? Because that's quick acting, in and out. But you still have to put them on 6 weeks of something. And you have to come to terms with your neurology group or whoever is following these patients after, that you're willing to take that risk. And to be honest, that risk is nowhere near where it was thought to be of hemorrhagic transformation. The other thing is when you get into the stroke business, asymptomatic hemorrhagic transformation or trace hemorrhage is a lot more common than, so we don't even think about it until you're symptomatic from it. So I think don't necessarily worry about that either. But I think at the end of the day, each case has its own little intricacies that you have to manage, but you have to be able to look at each case and have solutions for each possible scenario. And if you don't, that's where you come unprepared, and that's where those physicians may call you or me or whoever and ask, what do you guys do for that? And ask for help. I think you're going to be foolish because at some point in your career, you're always going to see something for the first time.
Absolutely.
And ask for help.
So for the tandem occlusions with the carotid and the, we'll say, MCA occlusions, you like to go after the distal one first if you can get through it.
If I can.
If you can't.
If I can't get a guider through, because I'm taking, whatever it is, a serum-based guider or whatever through. If I can't, I'll stent on the way. We'll leave a wire through it if I have to. and then go through my stent and go chase the lesion. That's not quite, and it's funny, and I don't mean it's funny, but it's interesting. The first time I did it, you hear all your old attendings in your head all the time. You can't go through a fresh stent, blah, blah, blah. Well, here we go. Like, when I was training, we never would take anything bigger than a microcatheter above the skull base. I do it all day, every day now. I mean, it's like the guy who trained me, he must be flipping out if he came and watched me do a case. You know what I mean? Because of the stuff that we put into people's MCA. I mean, you're taking a red 72 into a guy's M1 where they would not have ever taken anything bigger than a tracker 18 up. And so, that carotid's fixated at the skull base. You can't get into it, blah, 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 blah. So I think, going forward now, I think you just have to be kind of prepared. But I'll go through a fresh stent all day. If I have to justify it. I'd rather not, which is why I would rather get the lesion distal and stent on my way out. Because what are we trying to do? And I think we're gauged by the time that we restore flow. We're not gauged by the time that we stent the carotid.
Something I run into every now and then, though, is, where I go after that distal lesion first, because I also try to go after the distal lesion if I can get everything through it. But then, I'll take this, 88 catheter and push it through the carotid, through that stenosis. And I found that kind of acting as a balloon a little bit. And I'll come back down after and I'll shoot the carotid, and there's excellent flow through there. And then sometimes I wonder, am I better off just waiting and treating this later? You are better off
waiting and stenting the guy, even if it's 3 days later.
Yeah.
You are.
And that's kind of how I've been approaching it. If I can get good flow through there, and I don't think it's going to go right back down, like I usually just let it cool off. But I also think, based on the conversation we just had, because you've restored flow, that may not just be because of your Zoom 88. It may be that now you just have more flow going through and your carotid just looks a little bit better because the flow is quicker. So you're 100% right. In that patient, if they don't need it, they're not getting it. I'm not in the business. I will tell you this, I learned this a long time ago, and it's interesting. And if you hear me talk about collaboration, one of the things about, and if you were ever in a practice with a group of surgeons, one of the things you really can't hurt anybody. And the enemy of good is perfect. And good is good, right? And if I have to go back later and stent the carotid, I will. But I'm not doing anything I don't have to do that puts the patient at an added risk when I've already achieved my ultimate goal. You're 100% right, Mike. 100%. But some of that's flow related, but some of it is, you're 100% right. You took a tapered catheter, which was the Zoom 88. It slid through, but now it essentially did its own angioplasty. Take the benefit and run. Yeah, exactly. Wayne, that's about all I got. Is there anything else that's important to cover that I didn't go over?
Well, I just think going forward, like we talked about it a little bit, it's very interesting that there's a real push these days for outpatient services of what you and I do. And I think we have to be prepared for that in a good way. And even if you're doing it in a hospital, even if you're doing it and overnight, it's not going to be that way 5 years from now. I remember talking to some of my colleagues about, let's talk about hips for a second. In a million years, they'd never do an outpatient hip replacement. Really? That's all they do now. 10 years ago, in a million years, I'd never do that one. But we're going to be, and it's already happening in some places, coiling aneurysms, not ruptures, but and stenting carotids as an outpatient. And I think that's going to be interesting. So going forward with that, I just think as operators come out and they become more and more skilled, minimally invasive, better outcomes, less morbidity, it's just going to carry so much weight that we just better be prepared for more and more patients like this and better devices. If you really look at like carotid stents roll on a monorail, right? That's not a radiology product. Who came up with that? That's a cardiology product, the monorail. And it's okay, it's fine for what it is. But you almost always have a tech scrub with you. You don't really need it. So the devices are going to continue to change. They're going to continue to get better. But like I said, I think the real key to anything we do is know exactly the device that you're using, know how to have it ready, know what its benefit is, know what it's not good at. The reps are still, remember, a selling product. There's a lot of competing products out there, but know what's best for you in your hands, for your patient population, in your community, your institution, what you can see, what you can't see, what your imaging is good at. And like I said, don't be afraid to ask questions either.
Yeah.
I think going forward, our field is one of consistent growth, consistent innovation. And status quo is never going to be accepted, and it never has been. And it's been a real privilege to be a part of that too.
Yeah, it makes it fun. It's always exciting, always changing, never bored.
Never bored, makes it fun. You know, and you're going to laugh, but man, I don't know how often we all hear it, right? I got a guy.
That's
we
it.
Did a guy. We did a guy. Could you just? Could you just? And, when you're looking at carotid stents, like radiation patients, they're the perfect example. Nobody's touching them with an endarterectomy. But they're very safe from a stent standpoint. Get in from the inside and do what you got to do. The re-stenoses, get back in. We didn't really talk about what if you have re-stenosis of a stent, 6-7 years later, and I'll just put another stent in it usually. If that
Just put another one. Do you use the same kind?
That depends on what seems to be best. I have no problem using the same kind, but I don't usually just do angioplasty. I can't really remember the time I just did angioplasty of a carotid in the neck. Unless it was looking at webs and things like that to just tear webs, fibromuscular dysplasia or something like that. But for, I can't remember the last time I just did angioplasty in somebody's neck. And then you could touch a little bit on vertebral lesions because they're same patient population, stroke patients. But they're much smaller vessels, right? And you have to be really, really precise sometimes with the stent. So there we are using balloon mounted most of the time. Cardiac stents. I'm not using drug eludings, but we are using balloon mounted stents there. I can't tell you, Mike, what a privilege it's been talking to you. Thank you so much.
Thank you. We appreciate you sharing your expertise.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza,
Sabine Dond,
and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.